Bismillahirrahmanirrahim. I welcome you all on behalf of Pakistan Society for the Study of Liver Disease on this academic forum, which is hosted and sponsored by Gets Pharma to the WebEx. Here we have with us Professor Wasim Jafri. Sir is the head of gastroenterology and hepatology at South City Hospital as well as Khan University, professor at Khan University. Professor Saeed Hameed is with us. Professor Saeed Hameed is director, clinical trial unit and professor of medicine and gastroenterology at Khan University. We have Professor Zaighar Abbas. He is head of gastroenterology and hepatology at Ziauddin University, Clifton. And we have Dr. Amna Subhan. She's faculty at Khan University, practicing as gastroenterologist and hepatologist. And I'm your host, Professor Zahid Azam. I'm professor of medicine and gastroenterology at Dow International Medical College, Dow University of Health Sciences. Sir, first of all, there are some housekeeping announcements. Our participants who are joining us, this is the request that they should mute their mic so that the conversation of the speaker can be heard easily and there should be no interruption. And if you are, and also we should all keep our cell phone on silent mode. First of all, I would request Professor Wasim Jafri to start the presentation. His topic is overview of COVID-19. So,
can you hear me?
Yes, sir.
Okay, guys. Thank you very much for this invitation, especially to Dr. Zagam and his team for organizing this COVID-19 series. I think this is one of the series that are going to happen from this platform to address various aspects of COVID-19. Let me start, because there are constraints of time, with the presentation. This is going to be a brief overview. And let's start with the current statistics. Basically, when I was preparing it last night at around 1 a.m., there were 2,293,664 cases worldwide, with 583,783 recoveries and 157,400 deaths globally. Pakistan has a share, reported by Dawn this morning, is 7,918 cases, 1,832 recoveries, and 148 deaths. This is this morning from Dawn. We all know that the problem started in Wuhan, China, on 12th of December from the seafood market. However, it spread pretty rapidly in Wuhan and then rest of the world. What is the source of infection? The source of infection is none other than patient, and patient. So asymptomatic infected people can be a great source of infection. And that's how all the preventive measures of distancing and isolation and lockdowns and all that. So it is if we have it, we may not be symptomatic to start with and can actually be the source for many, many more who can then become symptomatic. The routes of transmission, initially, it was supposed to be only respiratory droplets and close contact. However, as experience grew, we knew that it is also isolated in feces and urine, and hence fecal oral route came into being, and contaminated surfaces from a day before or 2 days before can also become the source of infection. Who is susceptible? Everyone is susceptible from this infection. The pediatric population initially was thought to be, not so much, but as experience grew, we know that there are ICU beds in United States and others. From personal sources, I know that they are full of pediatric patients as well. And the pediatric age limit, which used to be 18, is now reduced to 15 for the sake of, logistics. The brunt of the injury falls on the lungs. We know that through autopsy studies and biopsies. However, I can tell you that no organ of the body can be spared like any other serious viral infection. And we have had lots of experience of dengue and others that certainly it starts with one organ, like our hepatitis C. It is a hepatotropic virus, but it can affect almost any organ of our body, and so is this COVID-19. Although the brunt of the injury is lungs, and majority of deaths are related to lung problems. However, the immune system is heavily involved with spleen, hilar lymph nodes, bone marrow, etc. The CD4 and CD8 cell counts are low, and pancytopenia in the bone marrow. We have had cases of Guillain-Barré syndrome. We have got cases of other problems as well related to different systems of the body, including, in fact, the heart and the digestive system and liver, with evidence of hepatitis going on to, in fact, there are instances reported from Turkey that they have had acute fulminant liver failure. And of course, through my personal contact, I've known that few patients have had even liver transplants related to it. The incubation period, however, is 1 to 14 days, mostly 3 to 7 days. The clinical features may start with fever, cough, and fatigue. I mean, what is so special about this fever, dry cough, and fatigue? We get it every year, every other year through flu and all that, but this is serious because we're passing through a pandemic, and this pandemic is related to coronavirus, and we should not neglect these subtle symptoms of fever, dry cough, and fatigue. It could be one of us suffering from it. The patients with severe or critical illness may have low fever or even no fever for that matter. And patients with chronic underlying diseases have poor prognosis, like liver disease, like heart disease, like diabetes. The pregnant women is similar to that, patients of the same age, so the clinical course may not differ. However, if there are comorbids with the pregnancy, then certainly it could have further effects. The children are relatively mild, but as I said, they are not immune from the problem and they may go into severe. However, my colleagues, the early warning indicators of severe and critical cases we must be familiar with. The peripheral blood lymphocytes decrease, progressively elevation of inflammatory factors such as IL-C and C-reactive proteins, lactate sustained or progressive elevation, and lung lesions rapidly in a short period of time become more and more like ARDS. All the laboratory tests that we are generally familiar with acute illness are elevated, like the C-reactive protein, the erythrocyte sedimentation rate. There is lymphopenia, the lymphocyte count goes down. The patients may have elevated liver enzymes, lactate dehydrogenase, myoglobins and muscle enzymes go up, D-dimers increase progressively, elevated troponins, and the inflammatory cytokines. The virological detection is through virus RNA by PCR technique, the RT-PCR, and it has to be through a nasopharyngeal swab, sputum, lower respiratory tract secretions, blood, feces, and other specimen using the RT-PCR. Specimens may also be collected for those seriously sick patients with bronchoscopy and by other means. Serological test, the IgM antibody becomes detectable in 3 to 5 days, and at the same time, the IgG antibody becomes detectable too. And if you have IgG antibody with a titer going as high as 4-fold increase in convalescence, it also confirms acute infection. Epidemiology is great help in isolating these cases. If you have traveled within the last 14 days to an epidemic community, you are a susceptible person. You may have been in contact with an RNA positive person in the last 2 weeks who may have had some fever or respiratory symptoms, or if there are clusters in the families, offices, schools, etc. For confirmed cases, you need to have virological and serological evidence through PCR and the antibody titers. We all know through China's lots of data that has come in that the disease is more morbid as well as more severe with increasing age. So as we age beyond 30, 40, 50, 60, we have got more and more serious cases, and more of those cases may end up in ICU. The treatment is ever evolving. We know that supportive treatment is exactly what is available to us right now. The antiviral treatment, which is more specific, is undergoing through lots of controversies. People have started using hydroxychloroquine. They have started using, in fact, in some of the Chinese studies with interferon, with glucocorticoids, you name it. You know, whatever we have, ribavirin has been used, etc. But there is not a single medicine yet approved by the FDA for use. Ritonavir, remdesivir, you know, all these medicines used for hepatitis, for AIDS, etc., have been tried, and still we are struggling for the magic treatment for antiviral treatment. Treatment of severe and critical cases involve the respiratory support, circulatory support, renal support. You have used convalescent plasma treatment, blood purification through plasmapheresis, etc., getting rid of all the cytokines. There have been immunotherapy and other therapeutic measures. So in short, with this very brief review, what I've tried to emphasize is that COVID-19 is an emerging infectious disease. It has emerged with an astronomical figures within the last 3-4 months, that many aspects still need to be elucidated. I'm learning every day. I'm sure everyone is picking up 1 or 2 things every day, including the pathogenesis and pathology. Early diagnosis and early treatment is state of the art, and effective oxygen therapy is very, very important. Thank you very much for your attention.
Thank you, sir, for this wonderful introduction. Now, I would request Professor Saeed Hameed. He's going to tell us about effect of COVID-19 on liver and digestive system.
Thank you very much, everyone, and thank you for organizing this on the platform of PSSLD. I'm going to share my screen. Just tell me if this is now available for everybody to see.
Not yet.
Not yet. Okay, we can just. Okay, well, thank you very much. And my task is to talk about effects of COVID on liver and the digestive system. How does COVID affect the liver and the digestive system? And we know very well now that this is through the angiotensin converting enzyme 2 receptors, which are the functional receptors of COVID-2, which help get this virus into the cells. This receptor is present abundantly in the biliary and the liver epithelial cells, particularly in the biliary cells, where it is 20 times higher as compared to the liver cells. The elevated liver biochemistries that we see in COVID patients that we'll talk about in a minute may reflect a direct virus-induced cytopathic or hepatotrophic effect and or damage from the provoked inflammatory response that this virus so consistently provokes. If there has been very few liver biopsies done, but if you do a liver biopsy, this shows moderate microvascular steatosis and mild lobular and portal activity, and does not show significant damage to the hepatocytes or even to the bile ducts, where the AC2 functional receptors are present so abundantly. In the intestine, in the GI system, ACE2 is also highly expressed in the esophagus, upper esophagus, particularly in the stratified epithelial cells, and absorptive enterocytes from the ileum and the colon, thereby causing enteric symptoms like diarrhea, which may occur due to malabsorption by the invaded enterocytes or through the invaded enterocytes. The virus is also present, we know, in reasonable quantities in the digestive system and is shed in the stool for quite some time. And we'll talk about this in a little bit later. It continues to be shed in the stool even after the nasopharyngeal swabs have become negative. And that is something that, as gastroenterologists, we should be aware of. So, what are the mechanisms through which COVID infection damages or can potentially damage the liver? We talked about direct hepatocyte damage, immune mediated damage, which we sometimes called bystander hepatitis, which means that liver is not the main target organ, but gets affected as a kind of a silent, well, not so silent, but as a bystander and causes some hepatocyte damage. It can certainly, as the disease progresses, it can lead to multi-organ involvement through what we now know from the literature is labeled as a cytokine storm, which means that there is the secretion of excessive amounts of pro-inflammatory cytokines, which cause end organ damage to many organs, including the liver. And fourthly, the liver could be damaged as part of drug toxicity. There are a huge number of medications, as Dr. Jafri has mentioned, being tried and tested, and other homemade remedies, and all these could lead to some delay. So we should always remember this mechanism as also. Now, here is a case which seems to be a direct cytopathic effect, and this is the only reported case that I could find, although there may be others, and this is from a hospital in New York, where a 59-year-old patient presented with the chief complaint of dark urine, no respiratory symptoms, nothing to suggest COVID infection, typical COVID infection. All markers, viral and other acute markers, were negative. You can see that her AST was around 1200, her ALT around 800 at the time of presentation. And during this time, a COVID result is sent and turns out to be positive. Well, I'm not sure whether hydrochloroquine did anything to the patient, but the patient did recover quickly. The liver enzymes settled down and was able to be discharged at day 8. So there's this reported case. There are others whereby an acute hepatitis presentation could be possibly associated. Okay, let me share my screen again. My internet is a little unstable. So we were on this slide. Typically, we get liver enzymes that are mild to moderately elevated. These are reports from China, which suggest that 14 to 53% of admitted patients could have derangements of liver enzymes, particularly AST and ALT. Men seem to be affected more with this bystander type of hepatitis. In most cases, ALT and AST are raised 1 to 2 times the upper limit of normal at presentation. And you see this bar graph, which shows from this particular study from Shanghai
ठीक है
that
वो आप अपना उस पर कर लें हॉटस्पॉट ले लें
that about 50% of patients had elevated liver enzymes, out of which 21% had
हॉटस्पॉट
raised
आपका लैपटॉप से कनेक्ट हो
AST.
जाएगा
ALT was raised
वाईफाई की तरफ यूज हो जाएगा आपका जो हॉटस्पॉट
18%.
अगर आप सेल फोन पे करेंगे सेल फोन पे हॉटस्पॉट ऑन करें
Zahid, can you switch your
वो आपको
Zahid?
कनेक्ट कर देगा
Zahid, can you
प्लीज
switch your can you mute your mic, please? Okay, so the point to note is that the AST levels are always a little higher as compared to the ALT levels. Bilirubins are not that high. Of course, low albumin is a predictor of severe disease. This study is interesting. It is not yet published, but reported from Columbia Medical Center. The higher the ALT and AST levels, they seem to suggest a worse prognosis. So anybody who has more than 5 times the upper limit of normal, 39% of these people ended up requiring ICU care and therefore had severe disease. So can very high levels be predictors of a severity of a severe outcome? Possibly. it could be the other way around, that severe disease leads to higher enzyme elevation. So this is the typical cytokine storm. I won't go into the details. So inflammatory cytokines like IL-6, interferon gamma, and others, TNF-alpha, etc., are released in huge quantities and they damage end organs. So for example, in 52 critically ill patients with multiple organ damage, 67% of them had lung damage, of course, which is the hallmark. 29% had acute kidney injury and 29% had liver injury. So about a third of these patients with the cytokine storm will get significant liver injury, and this may lead to liver failure. 23% have cardiac injury. In this particular study, liver failure has not been listed as a cause of death for any of these patients so far. So not primary liver failure is not listed as a cause. So what is the impact of COVID in patients with chronic liver disease who already have some sort of chronic liver disease? There is so far no evidence to suggest that patients with controlled chronic hepatitis B or C virus infection are at increased risk of acquiring COVID-19 infection. So they will get it at the same rate as anybody else. CDC data so far has 41 patients, or a little while ago had 41 patients out of 7,162 diagnosed cases who showed underlying chronic liver disease. So the numbers are small, and we can't really make any major predictions out of this or estimates out of this of what will happen to patients who already have chronic liver disease. In the Chinese data, 2 to 11% of patients had comorbid chronic liver disease, and the outcome really could not be determined as such. Infection with COVID may impact existing chronic liver disease in three ways. So it leads to hepatic decompensation, in other words, what we could typically call ACLF. It leads to viral reactivation in patients with chronic viral hepatitis, and drugs used for treatment of COVID may produce hepatotoxicity. I must say that the evidence for all of this so far is not very strong. So therefore, the recommendation is to include testing for SARS-CoV-2 or COVID in patients with acute decompensation or ACLF, because this could be related to SARS-CoV superinfection. What is the impact of chronic liver disease on COVID-19 infection? Pre-existing liver disease is not yet specifically listed in the comorbid conditions leading to poor prognosis, as was mentioned by Dr. Wasim Jafri. This is liver disease, this is heart disease, this is diabetes, this is old age, this is obesity, etc., etc. But we feel that it is a comorbid condition that would lead to poor prognosis. Elevated ALT levels, reduced platelet counts, and reduced albumin levels at admission have been associated with higher mortality. Quite likely, patients with liver cirrhosis-associated immune dysfunction, liver transplant, and autoimmune disease patients who are in immunosuppression remain at increased risk for COVID-19, and therefore, liver disease should be listed as a significant comorbid condition. As far as evidence goes, chronic hepatitis B infection does not seem to affect COVID-19 outcomes. This is chronic stable hepatitis B. However, patients with NAFLD may have comorbidities such as diabetes, hypertension, obesity, putting them at increased risk of a severe course of COVID. There are potential toxicities to all the therapies that are being utilized at the moment. I'm only going to mention three because many of them are not available to us. Remdesivir, in the compassionate study that was reported in the New England Journal of Medicine recently, 23% patients developed liver enzyme elevations. 2 patients had to discontinue due to significant liver enzyme elevations. So remdesivir does have potential toxicity. On the other hand, chloroquine and hydroxychloroquine seem to be very safe. There have been drugs that have been around for more than 50 years now, and clinically apparent liver injury seems to be rare in these two drugs as far as we can determine from a long history of use. So what are the recommendations for assessing liver function in patients with COVID-19? So ILCA has the International Liver Cancer Association and ASSLD have come up with recommendations. Both of them suggest that baseline liver tests should be done in all patients who are admitted with COVID-19. ASSLD also suggests that tests for hepatitis B should be done in these patients who have liver enzyme elevation. All patients with COVID should be regularly monitored with LFTs, particularly severe cases, because increasing as LFTs may be the harbinger of of an upcoming severe phase of the infection. In patients who have jaundice or hyperbilirubinemia, the need for imaging and other procedures should be carefully considered to minimize unnecessary exposure. So try and do without imaging if you can, if necessary, and entirely for the management, then only do them. The presence of abnormal liver tests should not be a contraindication to using investigational or off-label therapeutics for COVID-19. So anybody who has mild elevations is not ruled out of these treatments, but regular monitoring of liver function tests is required. So just to summarize, COVID and elevated liver enzymes, mild liver enzyme elevations are relatively common. Severe elevations likely in severe disease. Initial workup is recommended. Consider if there is underlying CLD and keep a very close watch. Exclude other causes of elevated liver enzymes in critically ill patients like sepsis, ischemia, DILI, etc. There are some unanswered questions. What is the extent that chronic liver disease should be considered as risk factors? Does COVID-19 lead to ACLF? It probably does. Can patients with stable CLD be enrolled in therapeutic studies? The answer is yes, with some precautions. So very quickly in the next 2 or 3 slides, just about GI symptoms. So accumulation of studies suggests nausea or vomiting in about 5% of patients, diarrhea in 2 to 10% of patients. However, this study on the right-hand side of your screen, published in American Journal of Gastroenterology, created a huge amount of concern because according to this study, 48% of patients of COVID who presented to hospital presented with predominant digestive symptoms as their chief complaints. So 45 had digestive and respiratory symptoms, 3% had digestive symptoms without any respiratory symptoms. So therefore, this really caused a significant concern. This was a multi-center study of 204 patients. There were some salient points that we wish to elaborate. Patients with digestive symptoms had a significantly longer time from onset to admission than patients without digestive symptoms. And this makes sense because nobody thought that the digestive symptoms are COVID-related initially. As the severity of the disease increased, digestive symptoms became more pronounced. Patients without digestive symptoms were more likely to be cured and discharged than patients with digestive symptoms. So a significant difference, 60% versus 34%. The index of suspicion, therefore, may need to be raised earlier in at-risk patients presenting with digestive symptoms. And this study prompted the American College of Gastroenterology to come up with an immediate release, a news item for people to say that this is something which needs to be considered. So what is the impact of COVID-19 on pre-existing GI disease? For us, probably just the inflammatory bowel disease part, because some of these people are on biologics and immunosuppressive agents, and therefore they need perhaps special care. The Chinese IBD Society has come up with guidelines, and that they are worth looking at for the management of these patients. Lastly, the presence of the SARS-CoV-2 or COVID-19 viral RNA in the fecal samples, which is a matter of concern. So let me just, this is a complicated graph, but just let me chart, but let me tell you very quickly what these two things mean. The red lines are the nasal or the nasopharyngeal swabs or the oral pharyngeal swabs. The yellow are the fecal RNA tests. So you can easily see at a glance that very, very soon, the nasopharyngeal swabs may become negative in many people, but the fecal samples can persist for nearly 5 weeks. So the yellow lines continue to go on into the next month and the next month. And that is the matter of concern. So viral shedding can last for nearly 5 weeks after the respiratory symptoms are tested negative. Presence of GI symptoms were not associated, however, with fecal sample being positive uh, uh, for the viral RNA. Disease severity was not associated with extended duration of fecal sample viral RNA positivity. And so far, there have been no cases reported of transmission via the fecal oral route as far as is known. So, to summarize the COVID and GI section, COVID-19 infection can present primarily with GI symptoms well before respiratory symptoms develop. So, be aware of this. I'm not saying test everybody with acute gastroenteritis that we have a lot in our country, but please be careful to take a history properly and see if there is any indication to consider a COVID-19 test. COVID-19 can have prolonged shedding in the stool of recovered patients. However, what is not clear is this shedding infectious? And therefore, if this is infectious, should we delay colonoscopy even for our recovered patients for at least 4 to 6 weeks? And I think that makes sense. And what effect can it have on the IBD patients? We still don't know. Thank you very much for your attention. I will stop.
Thank you, sir, for this excellent presentation on effect of COVID-19 on liver disease. So I would request now Professor Zaighar Abbas he's going to talk, deliver a lecture on advice, what we as physicians should advise to our patients with liver disease and also post-liver transplant patients. Dr. Zaighar Abbas.
Okay, yeah, Dr. Saeed has made my job very easy. So I'll discuss what advice should we give to our
Sir, adjust your
patients.
camera, please.
Hello.
Yes, this is okay, sir.
So I'll discuss a little bit about the advice that we give to our patients who are suffering from cirrhosis or advanced liver disease. So what preventive measures should they adopt? So these are one of the measures, preventive measures that we have been stressing that they should stay at home, avoid crowded places, visitors, parties, interest group meetings, or going to bazaars and shopping malls. They should delay their clinic visits. If this is not urgent, they should avoid elective hospital visits and be careful if you are having any comorbids like diabetes, hypertension, or obesity. Like Dr. Saeed has mentioned, that patients with FLD and cirrhosis, they are more prone to have complications if they contract COVID because of these comorbids that they may be having. So while you are staying at home, you have your good ventilation, open your windows and doors at least twice a day, eat a balanced diet, vitamin supplements should be taken. So if the patient has bled previously from the varices, then you may advise that they should take soft food to reduce the risk of bleeding from dilated veins, and they should engage themselves with educational sessions, internet meetings or Zoom meetings. They should continue with light exercise while staying at home, monitor blood pressure, heart rate, and urinary volume because they have to do this self-monitoring if they have been on diuretics, if they have been on beta blockers for rashes. And so that is very important that they should take their medication on time. If they have been on some special medications like medicines for autoimmune hepatitis, or similar medicines for other viral hepatitis, they should continue with those medicines. So immunosuppressives, if they have been or they should not stop because this will end up in flare up of the disease. They should limit hospital stays and hospital visits. If they have to go for some special concert, they should first go to the family physician, avoid hospital visit. If they have to go to outside, they should wear gloves, caps, and face masks and use the mask properly to adequately cover and seal the mouth and nostrils. Get the adequate drug supplies. So it's preferable that they get a 90 days supplies instead of 30 days supplies. And this is also recommended that they should get vaccinated for Haemophilus influenzae, Pneumococcus pneumoniae, and uh, other prophylactic vaccinations. So when they return home, they should not touch everything. They should take off their shoes and outer coats outside in the balcony, throw away the face masks and gloves carefully, not to touch the outer surface of these things. They should thoroughly wash their hands, face, and exposed areas. Wash the hands for 20 seconds, like we advocate for these. All the for prophylactic measures. And if they had taken their cell phones, glasses, and other things outside, they should properly clean. If they are glasses, you may have soap with water, or then alcohol wipes may be used for these cases. Patients are not feeling well, then they should contact their doctor on WhatsApp, or they should contact the helpline of the hospital. For urgent issues, if they have to visit hospital, they can do so, like if they are having hematemesis, ascites, dizziness, low urinary output, worsening jaundice, or intractable vomiting. So if they were on the transplant list, for transplant list, I mean living donor liver transplant list, they can postpone it uh, if there is no urgency. But for the high med score, they have to continue with the evaluation for liver transplant. Also, liver transplant, living donor liver trans is recommended if they are presented with acute or chronic liver failure, because in these cases we cannot delay the liver transplant. So if they are not feeling well, they should contact their doctor and do accordingly. They should get their COVID test, and in case of they are symptomatic, like having cough, fever, shortness of breath, or diarrhea, and if they are on the transplant list, it's very mandatory nowadays that they should get tested for COVID. Both donors and recipients should be tested for that. If the COVID test is positive, then if the patient is not serious, then self-quarantine at home is advised. And these patients should observe all the precautions, and they ask the caretakers to take appropriate precautions. But if they are having symptoms, or they are having a severe sort of symptoms, including decompensation, they should get hospitalized. For patients who have their liver transplant, they should be very much careful. They should stay at home. They should minimize in-person visits and interaction with healthcare workers, opt for telemedicine, and they should not stop their immunosuppression. They should continue with the immunosuppression. But if they contract COVID, then they should again continue with tacrolimus or cyclosporin, but one may think of reducing the dose of prednisolone, azathioprine, or mycophenolate. If the patient was having liver cancer or hepatocellular carcinoma, then it is recommended that they should not delay the liver cancer treatment, and they should follow the usual guidelines for the treatment of hepatoma. If the patient has already received some treatment for hepatoma, and no 6 weeks surveillance CT scan is due, then this may be delayed for 1 to 2 months. If they get COVID-19 infection, then these patients should be hospitalized. So these are the guidelines that have been published about the COVID and liver disease. Thank you.
Thank you, sir. Now, I would request Dr. Amna Subhan. She's going to talk about uh, doing endoscopies and the care that we should observe during endoscopies. Dr. Amna Subhan.
Okay, so thank you very much, Dr. Zahid, and thank you very much, Pakistan Society, for the study of liver disease, and thank you very much, my mentors, Professor Jafri, Professor Saeed, Dr. Zaighar, for giving me this opportunity to speak on this important topic. So I think this aspect of our webinar addressing the precautions during emergency endoscopy for liver disease is very important. But one general fact about this is the main precautions recommended during endoscopy for the liver diseases. These are actually sort of same as is actually recommended for non-liver patients. So probably the applicability of this presentation will be for many people. And we need to just remember that the recommendations are actually same for all liver and non-liver patients. So this is important because again, the transmission is actually can happen in these patients from not only from symptomatic patients, but also from asymptomatic patients. And unfortunately, now there are like many healthcare providers who have been affected by this disease, and definitely the number of deaths are increasing among the physicians as well, which is actually again of quite concern. So one of the paper which is recently being published on 5th April, so they have tracked the physicians' mortality by searching on the Google, and they found 198 deaths among the doctors, other than healthcare providers, including the nurses staff, but these are again the doctors. And one of them is actually a gastroenterologist. And unfortunately, this gentleman was from China, and he suffered from this disease and no more with us. So the safety, while we are the front liners and again the physicians who's our army, we have to stay in the ground and we have to help people. Then on the other hand, we have to take care of our safety as well, because otherwise the physicians and the healthcare providers, if they will not stay healthy, probably will not be able to help others and themselves as well. So the fact number two, which is again very important, is again this is repeatability, that the aerosol generating procedures will generate small droplets and in high concentrations, and that actually permits an airborne transmission. So all upper GI endoscopic procedures, including endoscopy, small bowel enteroscopy, ERCP, endoscopic ultrasound, breath test, and esophageal manometries, they are potentially at high risk to transmit this COVID-19 virus. And as Dr. Saeed has mentioned, the stool is a source of transmission, and that actually led to our attention towards the colonoscopy procedures, because during that procedure, one can is actually be at risk for the transmission of this virus. Now, what precautions should be practiced while we are actually working as healthcare providers? So the number one piece of advice is again from the most of the societies and authorities is triage and screen the patients by a trained medical professionals. Um, it would help is actually to decide about when to do the procedures and where we can actually make it delayed. So far for the screening and triaging, different type of strategies are used in the different countries. The screening by using a questionnaire is actually used everywhere, where you can focus on questioning about have you been diagnosed with a case of COVID-19, traveling history, direct in contact with a patient of COVID-19 case, or somebody is actually symptomatic. But we know that if somebody is actually on in incubation period, and now this is a time when there will be lots of carriers among us who are asymptomatic. So this screening tool is actually not pertinent for them. So now that actually raises an actually a question about should we screen all patients before endoscopy or not? So testing will be more safe, but is actually not convenient everywhere, especially where the resources are limited. And again, testing with what? The serological test, where the accuracy is again questionable with the available kits. And again, the PCR results is actually takes time. So what to do in emergency situation? So for time being, where the facilities are available, the people are testing, but the wide applicability of this recommendation is very, very questionable. So the third thing is actually assess the risk of having COVID. So we can actually divide them individuals or the patients into three categories. One is people who are at low risk, and this group will include those patients who are asymptomatic, not in contact with any positive patient, non-stay in a high-risk area during last 2 weeks. So the people who are having some symptoms on the presence of symptoms with no medical history of contact, and without any stay in a COVID area, no symptoms, but in contact with COVID positive patients, or they have stayed in a high risk area, they are categorized in intermediate risk. The high risk patients will be those who have either one symptom, or they are in contact with a person and they have traveled in a high risk area as well. So after triaging, one can identify low risk, intermediate, and high risk patients. The second step is, after identification of these group, we need to decide about, we need to be selective that should we go for this procedure or should we postpone it. So for that, decide about and offer the procedure what time sensitive, which means that they are required to be performed within 24 hours, or they can be actually deferred within up to, they can be performed up to 8 weeks. For instance, if there is a threat to the life of the patient because of that organ dysfunction or a disease, for example, patients with cholangitis, upper GI bleed, food infection, and the people who are hospitalized because of any of these conditions, these are the patients where endoscopies, risk and benefit, if you look at the risk and benefit, endoscopies will be required and will be done within 24 hours. So these are the emergent cases. So there are non-emergent cases where, for example, the risk of metastasis or progression of disease will be high if they are untreated or they get rapidly worsened. For example, the people with intermittent lower GI bleed, but they are mild, the people who have underlying ulcerative colitis, and right now they have flare, and because of some reasons they need, and there is an indication of sigmoidoscopy here, you can opt for these cases. So the non-time sensitive cases means these cases where there is no emergent indications, and these patients can wait beyond 8 weeks. For example, screening colonoscopies, for example, is endoscopies for dyspepsia, for intestinal metaplasia, here better to defer. So saying the same thing in a different, again, revising the same indication, because this will be important information for the many people. So the urgent endoscopies that actually judicially could be performed during this COVID pandemic includes upper GI bleeding, management of perforations, leakage, biliary sepsis with cholangitis, foreign bodies, obstructions requiring stenting, and then again, in this is APSD who recommended for GI access for urgent feeding, but ACG and ESGE hadn't included this thing as an urgent endoscopy. And the same item, for example, endoscopy treatment of by EMR, ESD, suspicious area of cancer to take a biopsy, a small bowel enteroscopy for GI bleeding, ERCP for biliary pancreatic cancer who are not having cholangitis. So you've tried a patient, divided them into low, intermediate, high risk patient. You've decided that should I go for this endoscopy or not? And if the answer is the endoscopy is needed, that what precautions or PPE one can actually adopt during an endoscopy. So these are actually, so somebody who's actually triaging physically, for example, in the hospital, then these type of PPEs are required, which include face mask, shield, goggles, surgical masks, especially if the patient is actually at low risk, gowns, gloves, when there is a skin lesions or there is actually a chance of contact with body fluid. So the recommendation for suspected and confirmed cases, so you need a better PPE with full support, which include cover all body by, for example, these type of gowns, which are actually not permeable for the water. And again, N95 mask, face shield, hair net, and again, gloves. Double gloves when you are performing procedure, and shoe cover, and especially if the patient is COVID positive, then it will be better to have long shoe covers. So should we go for the entire PPE for upper GI endoscopy and colonoscopy both? It's better to go for both. But in resource constrained settings, the question of having full PPE, just like in upper GI endoscopy for colonoscopy, is debatable. But for the better safety, wherever the facilities are available, PPE should be followed for both as the same. So what about the strategically assigned staff to minimize the exposure? So one experienced endoscopist, 2 nurses for each endoscopy room will be enough. Same team of endoscopy staff should serve the same room for the same session so that there should not be too much switches between the procedures. No procedural professional should avoid entering in the endoscopy procedure once the patient has entered into it. So this is for both COVID suspected and COVID positive patient, because we don't know, a patient could be actually in an incubation period. So until proven otherwise, treat every patient as a COVID patient. So, if the procedure, so it's better to have a room with negative pressure. And when you're taking a new patient in, there should be a gap of 30 minutes. But if you don't have a negative pressure room, then there should be a gap of 1 hour after cleaning in everything. So the places where the facility of negative pressure rooms are not available, one option is to use HEPA filters, and that can actually be easily used. So if the patient is in ICU, then you can go there to perform where the environment will be more safe and better. What about the proper donning and doffing? So this is extremely important, proper donning and doffing. So when you are wearing your PPE, so the sequence will be wear the gown first and tie up the upper knot, then the lower knot. Then you can wear your mask. In the picture, there is a surgical mask, but definitely should be wearing an N95 mask. In the Europe, this is N99, and there are other options, respirators and PEPRs. Wherever is available, you can wear. You can have like those, then goggles, and then gloves. Remember, so whenever you are performing a procedure, better to use double glove of pair. This will actually help you, because if your hands or if your anything is actually get contaminated during the procedure, then you can actually you can remove one pair, and then the second pair will be there for your safety. So how to doff, how to remove the PPE. So when you are removing, there are two types of strategies that you can use. For instance, first remove the gloves, and when you are removing the glove, take your finger from inside and take it out in an inverse way, and just like this, so that this will be actually upside down folded. And after removing the glove, then you can take out your face shield and goggles, and then the gown. The gown should be again this way. So the most contaminated export part with secretions could be your sleeves and again the front area. So when you're taking it out, take it out upside down so that it will be folded, and then you can throw it into the bin. And then you can remove your face mask after that. Then again, face mask, open up the tie from here, or if there is an N95 mask, there is a special technique to remove an N95 mask. There are lots of videos available on the YouTube. You can watch there. Within interest of time, I'm not showing that video. And then wash your hand or use a good sanitizer. Perform hand hygiene in between the steps as your hands become contaminated immediately after removing your all PPEs. The second way of doffing is this one. For instance, before removing your gloves here, you will start from your gown. So open up the ties from the back, or ask someone to open up your ties from the back, and then take your gowns, remove your gowns towards the front, and inside of your gown, again, remove your gloves, fold it, and then throw it into the bin. And after that, you can remove your face shield, then mask, and then you need to wash your hands. So this way you can actually, this donning and doffing is again very, very important. It will actually save you to get contaminated from the body secretions. So how about, because the situation right now, there's lots of speculations and lots of predictability about that this pandemic phase, the corona is going to stay for a long. So let's see what will happen in the future. But what about in the places where the burden is actually going down and the new cases, there is a downward trend in the new cases. Here, the endoscopy source is actually can think about resuming their activities, but remember, better would be until there is an extreme certainty in your country about that now the new cases are going down and down and down. There should not be any hurry in doing elective procedure. Please don't do this. So So the guidelines right now are not very clear. So there are few papers from the China where they've started, they're resuming their normality gradually. In here, but you can see that if there is a good trend in downward trend in new number of COVID cases, then urgent endoscopy continues, semi-urgent endoscopy you can resume with full capacity, elective endoscopy with 50% capacity, but this should be a gradual one. So a country for like Pakistan, I think we are a little far from this phase. So we should not do any hurry, and we should wait for a better safe time. So the take-home message is again effective infection control and preventive measures essential to preventing this iatrogenic disease transmission. Remember, outbreaks has been reported in endoscopy units. So if endoscopy unit will be a source of spread, this is an iatrogenic. We should be avoiding it. A clear workflow must be established for both screening, disease stratification, for conducting the procedures with appropriate use of PPE to protect both healthcare providers and the patients. Thank you very much.
Dr. Amna, for this excellent talk, and especially for giving us opportunity to learn about how to put on your PP and how to take it off safely. Now this is the end of the session. This is the time for taking question and answer. So I'll start. I have received questions from different people. So I'm going to take one by one. So this is Server Solangi who's asking, sir, how you see present situation of pandemic of COVID-19 in Pakistan and predict about the situation in near future. This is with Professor Wasim Jafri. Sir.
We all learn through official figures have been based on limited number of tests because we cannot afford to have lots and lots of tests. And then, of course, as we improve on tests, then certainly our numbers would be, increasing as the number of tests would increase. So the exact figures that have been told to us by the provincial and federal governments are based on the number of tests that they're doing. So I am skeptical about the numbers themselves, but at the same time, if I was at the helm of affairs myself, and I have to really find out ways and means to do everything at the same time, to provide poor with the rationing, to provide, general life structure for our human beings and fellow citizens. I just don't know how I would, initiate the process of doing X number of tests in order to determine all those patients that would be having the virus. That is the ideal situation. And we don't live in an ideal world in Pakistan, most unfortunately. Majority of us do not live in that ideal world. So I guess the numbers really do not tell us the exact figures, but at the same time, that's the official figure, that's the world is looking at. That's what the United Nations and the WHO and all those figures are. So as an individual, I may be skeptical, but at the same time, I do not know the reality on the ground. So hence, what I see that our problem may actually continue in different shapes whatsoever. As Dr. Saeed has mentioned about the liver and GI, I have given you an overall figure. So it will actually come to us in different specialities over a variable period of time. And certainly people who have got lots of other comorbids and diabetes and heart disease are extreme comorbidities for patients to bring in more serious COVID-19 patients to ICU and to other things. God forbid, if those figures would keep on rising, we are in this situation for an extended period of time.
Thank you, sir. Next question is with Professor Saeed Hameed. Sir, the question is, does the presence of decompensated cirrhosis being a pro-inflammatory state makes chances of cytokine syndrome more likely than otherwise?
Theoretically, one would say yes, for two reasons. One, that the decompensated cirrhotic is in an immunocompromised state, so therefore may be likely to get the infection much more than somebody who's not in that situation. And secondly, for sure, this is the person who is liable to then develop an acute and chronic liver failure or acute severe decompensation. Uh, the data so far from across the world is not entirely clear on this because the numbers of these people are not so big in this series so far. But I think as we go along, we will start to see data that these people are certainly one of the high risk groups that I mentioned, and they should be included in the high risk group of people.
So next question is again with you. This is a scenario that Ghulamullah Lail has asked. A doctor who is infected with chronic hepatitis B and he's on treatment with nukes. Um, does he have additional risk of liver injury if he's posted at COVID isolation ward as a duty doctor?
Well, so there are two aspects to this. One, does it make him more vulnerable? Chronic hepatitis B, I presume that this is in a stable condition, being treated properly. Does it make him more vulnerable to acquire COVID infection? And the answer is no, it does not make him more vulnerable unless he has decompensated liver disease. Secondly, if he gets COVID infection, does it reduces or increases the prognosis for severe disease? And again, from the limited data that we have, the answer is generally no, although there are maybe one or two papers who suggest that chronic hepatitis B infection can be a contributor to the disease severity of COVID. So the data is not yet clear, but most of the guidelines that you read suggest that chronic hepatitis B, stable chronic hepatitis B, is not does not lead to severity, increasing severity of COVID so far.
Right, sir. Sir, again, a similar question. Any precaution recommended for HCV patient on treatment for COVID-19? And similar, like another question on hepatitis B. Both are, I suppose, non-cirrhotic.
So, do you mean to say a TB patient who's taking TB drugs, what is his risk if he gets COVID-19?
No, he has asked, there are two questions. One has asked hepatitis B stable patient
Yeah.
on treatment, and the other one is hepatitis C patient, stable patient on treatment. I suppose they are talking about without cirrhosis.
So the answer is the same,
Right.
even for hepatitis C patients. No problem.
Uh, this is the Dr.
The one thing only, just to mention one thing more. If you are starting or somebody is starting on therapy for COVID-19, please make sure that there are no drug-drug interactions with hepatitis C drugs or, for that matter, hepatitis B drugs. Thank you.
So this is the question from Professor Wasim Jafri. Dr. Abdul Qadir Khan has asked about, he was referred a kid of 11-year-old yesterday in his hospital, and many of the hospital and clinic are off, and the patients are suffering from fever, and thalassemia. No hospital was entertaining him. Should I see him or not? Though no symptoms otherwise except fever.
Of course, you need to see him. He is someone who may be having, not necessarily COVID, because of course he may have it, but at the same time, keep your distance from him. Of course, order the necessary lab workup for him. And of course, the simplest treatment in the presence of normalish LFTs would be to treat him with anything like acetaminophen or Panadol. But you know that studies from Italy and other places have vividly told us that brufen and non-steroidal anti-inflammatory medications, somehow those patients who received them were very badly affected with COVID-19 scenarios. So be careful with the use of NSAIDs, but otherwise keeping a distance, ordering the necessary labs for him. Even it could be on telephone. In fact, one can order the labs just to be reassuring that his lymphocyte count is good, and his normal white cell count, his LFTs. And then for the time being, as you would always treat symptomatically before jumping on to any serious conclusions. God forbid if it turns out to be COVID, then he needs to be referred to the proper unit so that he may be kept in isolation away from his family, and at the same time, in fact, treated accordingly.
Thank you, sir. This is the question with Professor Saeed Hameed and Professor Zaighar Abbas. Uh, this is Dr. Nadeem Thiami. He's asking about the he's agreed that we should have alternative to endoscopy and liver biopsy procedures, uh, like using non-invasive non-invasive markers of fibrosis instead of doing liver biopsy. But what Professor Hamed and Professor Abbas advise for suspected autoimmune hepatitis cases and indeterminate liver lesion? And are you still doing OP fiber scan, outpatient fiber scan?
Yes, may I answer this?
Yes.
So I think fibroscan may be done whenever we see a patient. We observe all the precautions. Like in this COVID era, every patient who walks in, one should consider suffering from COVID until proved otherwise. So fibroscan is not a procedure that should be deferred because we have to uh, because this is not associated with any droplet spray or anything like that. If you are wearing gloves, if you are wearing an 95 mask and you are observing all the precautions, I think fibroscan may be done. And as far as the liver biopsy is concerned, if you want to have a definite diagnosis and if the patient is severe and you cannot postpone it, then it may be done. Otherwise, this is in many cases an elective procedure and it may be postponed.
I have an opinion about the fibroscan. Basically, I don't think that's ever an emergency procedure, no matter what the circumstances are. So, hence, in fact, for a question that can a fibroscan be done in the current scenarios, Zagam can actually know a little bit about his own center, what kind of precautions are observed, but randomly, the question and the answer to that question is no. A fibroscan should be postponed indefinitely till the situation gets less alarming and hopefully things settle down.
This is another question from Dr. Amna Subhan, and this is Agha from Faisalabad. Uh, he's asking, do we need separate PPE for every patient, or we can use one PPE for a session like 4 to 5 cases if this is not soiled in session of endoscopy?
All depends on the availability of in your center. So if there are like if you're using the same strategy, the same room, and the patient is suspected not COVID positive, then there could be actually you can have a midway. For instance, the hairnet will be the same. The gown will be the same. At some center, the people are actually recommending that wear a scrub, and over a scrub, wear a gown, and then wear another cover. So for these type of situation, for example, the plastic aprons we use for the routine endoscopies. So if these are not COVID positive, but you don't know the status, in these cases you can wear the upper cover. You can remove the upper cover, and then you can continue the same PPE, the same N95. The one more protective options, a few people is actually recommend if you could wear a surgical mask over and above your N95 mask for that procedure. So the chances of flesh and the chances of secretion on an outer surface of N95 mask will be low. But if the enough number of PPEs are available, then should be changed after every patient, especially if the patient is COVID positive. So all depends on how much are the resources available at your center. But before leaving the room, you should change. You should actually remove the entire PPE that was used in that room.
Okay. Now, I suppose I'm taking this last question, and this is from Professor Jamil. He's asking that from Dr. Zaighar Abbas that as internists, they are seeing patients who are on steroids for one of the reasons. And do we need to continue the steroid the same dose in the era of COVID, though the person is not COVID positive, but do we need to continue with the same dose or do we need to reduce the dose? And do we have any concrete evidence for reducing the dose if that may harm the patient?
I think if the patient is not a COVID patient, he should continue with the same dose because if we reduce the dose, there is a risk that we may flare up the original disease. So I would say that it's not be a good thing to reduce the dose of COVID just as a prophylactic measure. So we should not reduce the dose for any patient who has been on. I think same is true for the other immunosuppressive drugs, like patients on the immunomodulating drugs or patients who are getting some drugs for liver transplant. So there is a risk that primary disease would get flare up, and so we should continue with the same dose.
Thank you, sir. And this is the end of the this webinar. I hope that people must have enjoyed my mentors, and I'm thankful to Pakistan's PSSLD for this initiative, as well as support from Cats Pharma. And we all are available via our email and IDs. If later on people can ask us with the speakers. Thank you very much.
Thank you.